Good afternoon. My name is DeAndre Brown, and I'm with the University of Maryland Capital Region Health. And today we are live discussing heart health. Today we're joined by Dr. Jamie Brown, who's the Associate Professor of Surgery with the University of Maryland School of Medicine and the Director of the Cardiac Surgery Program at University of Maryland Prince George's Hospital. Dr. Brown, thank you for joining us today.
Thank you for having me.
And to everybody who's watching now, we invite you to leave a comment for this live segment in the comment section below, and then also let us know you're watching the segment by either liking the video or liking our Facebook page. And so, to get started today, I want to go over a brief discussion about heart health, Dr. Brown. And so, please explain to our audience what being heart healthy means and why it's important.
Well, there are a lot of things that go into being heart healthy. One of them is being active every day. So that can be as simple as a walk a mile, walk a half a mile, whatever anybody can do it. We always say, start somewhere and go at it every day and try to build on wherever you begin. Go to the mall, go to a treadmill, walk to the park, whatever the weather allows, but stay active every day. A walk being the simplest thing you can do. The other part of being heart healthy is eating well. And to keep it simple, we tell people to eat a diet that's rich in fruits and vegetables that span the colors of the rainbow, with low-fat, small serving-sized pieces of meat. And when we talk about serving size, that's usually the hardest thing for people, especially men who are big eaters. So a serving size for a piece of white meat chicken is the size of a deck of cards, and that's hard for all of us. But lean and mean is the way to go, and that's heart healthy eating. So diet and exercise.
Got it. And so, when it comes to diet and exercise, obviously blood pressure plays a big part. So, how important is that in heart health itself?
Well, blood pressure is the silent killer, and that's hugely important. It's one of the major risk factors for cardiovascular disease. The really good news is nowadays that there are so many good medications that can control blood pressure effectively, and even if it's difficult in a certain patient to control, there are combinations of medications that can get the blood pressure under control. But having high blood pressure stress the heart and the blood vessels is not a good thing long term. So it's easy to get it checked and easy to get it treated now. So that's an easy recommendation to make.
And so, speaking of heart conditions, recently your patient, Mr. Charles Jacks, was diagnosed with a thoracic aortic aneurysm and then an aortic valve stenosis. So can you tell us a bit about the case and what you did for the procedure?
Well, Mr. Jacks had a blocked aortic valve, which is a very serious life-threatening condition. And he also had an enlargement of his aorta above his heart. And so both of those conditions can exist separately. Sometimes they exist together. But in either event, when the aortic valve is blocked, it blocks the blood flow to the body when the heart ejects. And over time, that's a very serious condition. Luckily, these days, there are ways to safely replace that valve with either open surgery, such as in Mr. Jack's case, or with a valve that's placed over a catheter. Given that aortic valve stenosis, as this is called, is such a life-threatening condition, replacing the valve returns patients to their normal life expectancy and normal quality of life.
Thank you, Dr. Brown. And so to hear more about Mr. Jack's story, you can visit our webpage at www.umcapitalregion.org/heart. And so, Dr. Brown, you talked a bit about the aortic valve stenosis. So also, can you touch bases as to how common it is?
So aortic valve stenosis is more and more common the older the population we're talking about, so that by the time the population reaches the age of 80, up to 10 to 15% of those people may have severe aortic stenosis. There's also a 2% of the population that is born with a 2-leaflet instead of 3-leaflet aortic valve. And those people are more likely than the normal population to get aortic stenosis or aortic insufficiency, we call it, or when the valve leaks. That's known as aortic insufficiency.
And so what would you say are some of the symptoms, and then can this be diagnosed early?
When people have heart disease, especially valvular heart disease, one of the main symptoms is shortness of breath and easy fatigability. So they may walk their normal distance to work or up 2 flights of stairs, and one day they realize, wow, I'm really out of breath from doing that. And that's a change. And that light bulb moment is very important, because a lot of patients just write it off to getting older. It can come on very slowly. So the walk to the mailbox, for example, they used to do very quickly, but now they take 3 times as long. And they very commonly will write it off and say, okay, I'm just getting older. But we know that if we take patients with severe aortic stenosis, blocked valve that is, and we test them and stress them a little bit, that more than 50% of them will actually have symptoms and have severe aortic stenosis, and thereby be ready, medically ready to have their valve replaced.
And so, are there treatment options available, and must the patient undergo surgery in order to correct the problem, or are there any other like medications or something that could correct the problem itself? So
for a blocked valve such as aortic stenosis, it's like having a normal supple valve in a human turn into rock. And there's not medication that's going to make that better. That valve needs to be replaced. However, if we're talking about a leaking valve, and the partner valve to the aortic valve is the mitral valve, and if the aortic valve leaks, in both cases, when the tissue is normal, surgery can be done that hopefully will repair those valves, and the patient can keep their own valve.
So thank you for that insight. And so switching gears, let's talk about a less common heart condition known as thoracic aortic aneurysm. What is a thoracic aneurysm, and then how common is it for someone to be diagnosed with this condition?
Aneurysm disease is not as common as coronary artery disease, but it is actually very common in the population. So an aneurysm is when the blood vessel in the body increases typically to more than double normal size. Then we say there's an aneurysm. So let's say the normal aorta that attaches to the heart is 25 millimeters or an inch and a half in diameter. So once it gets to 2 inches or 2.5 inches in diameter, then we're getting to be pretty wide, and that's called an aneurysm.
Okay. And so what are some of the symptoms that a person with this condition would basically, what would they experience? And then again, is this something that can be diagnosed early?
It can be diagnosed early. Unfortunately, it also can be a silent killer, because if someone doesn't have any symptoms from an aneurysm, there's no particular way, unless they happen to be in a CAT scan for something else or getting some other test, to notice it, right? But the symptoms that can occur with an aneurysm are pain is the main one. And that pain can be in the front, it can be in the abdomen, it can be in the back, right between the shoulder blades. It tends to get people's attention. Usually someone like that will mention it to the doctor or come in to be seen and describe it, and through getting a CAT scan or an ultrasound, they'll find the aneurysm.
And so if they are able to, let's say hypothetically people are, or a person is able to catch it early, what would be the treatment options for that? Again, is there any medications, or is it just a surgical option that's available?
So there are points in size that we measure pretty precisely with CAT scan these days, where an aneurysm reaches a trigger point. We call it a trigger point. And a trigger point is generally where the risk of the aneurysm rupturing and causing a life-threatening situation is high enough to warrant the risk of intervention. So let's say that number is 5 centimeters or 5.5 centimeters, maybe even 6 centimeters. We take someone who has a known aneurysm, and if it's below that number, they get really good medicine and really good control of their blood pressure. And then the day comes when they either have some pain or the aneurysm reaches such a size where we say, okay, the risk and benefit and balance of surgery means that we should go ahead and repair the aneurysm.
Okay. So thank you for that insight, and I'm pretty sure this information is very helpful to our audience, especially if they don't know that they could be experiencing such a heart conditions in which you mentioned.
Yeah, I think certainly anybody that's had chest pains needs to get checked out. That could be their heart or it could be their blood vessels. I think anybody with a family history where they've had a close relative that's had aneurysm surgery, or unfortunately has passed away because of an aneurysm, should probably be in the care of their doctor.
Okay, perfect. And so speaking of heart conditions and previous family history, I want to move into our question phase where we take a couple questions from our audience. And so at this time, if you would like to ask a question, I invite you to leave it in the comment section below. Again, we've been speaking with Dr. Jamie Brown, who is talking about heart health and how to stay heart healthy. Are there any questions from our audience?
There are. So we have a couple questions today. You've touched on the answers to a few of them, but it's good to reiterate what we're talking about today. So the first one, it talks about what's dangerous about aneurysms and blocked valves.
Well, that's a good question. I'll take them separately because they're two separate disease entities for the most part. So let's take the valve first. When an aortic valve is blocked, for example, normally the valve opens to the size of a $50, maybe a quarter. So the heart pumps, ejects blood to the body, goes through a nice big hose. If you can picture your garden hose, think something that's bigger than a garden hose. But if the valve narrows down, it goes down to the size of a nickel or a dime. So that means the heart has to work double hard, triple hard, quadruple hard, and for a while it can compensate. And what it does to compensate is get thick, but a thick heart's not a healthy heart. So eventually that cycle reaches its limit and the heart cannot compensate. And the patient's at risk for getting very ill or very ill suddenly. So that's not a good scenario. Those are the dangerous things. And if you had to compare it to something, if someone has really severe critical aortic stenosis, blocked valve, that is, and it's narrowed down to that dime, then their life expectancy over 2 years is sort of equal to one of the worst kind of cancers you can imagine. But the really good news about this day and age we live in is that there's so many good options to replace that valve, and it puts the patient back in normal life expectancy. So it's sort of like having something really dangerous that you can fix with very low risk and put the patient back on a normal curve for their life and their quality of life. So the second part of this is the aneurysm. So an aneurysm that gets too big, if you can picture the last birthday party you were at and blowing up the balloon. As you blow up the balloon's getting thinner and thinner and thinner. And if you kept blowing it up, the balloon would break. And that's exactly what happens in a blood vessel. When the blood vessel gets big enough, the wall gets thin enough, there's still the blood pressure the same pushing on it, and the stress as it gets bigger can eventually make it rupture. The idea is to head all that off at the pass and find such things before they rupture, because that creates a life-threatening emergency.
Okay, great. And that leads us into our next question. So if anyone is however diagnosed with an aneurysm or a blocked valve, is it possible for it to correct itself?
So there's no medicine or herbal remedy or anything that'll make an aneurysm go away. Once you have one, it's there to stay. And if you can think about it this way, you have an aneurysm, and you've got a segment of your blood vessel that's twice as big as normal, but your blood pressure is still the same. So it's still a fairly high pressure hydraulic system. Yet if you pictured the water in your house being under the same pressure as your blood pressure, that'd be pretty high pressure. A shower would hurt. So in this case, I think the thing to do while you're keeping a close eye on the aneurysm is really good blood pressure control, because if you can imagine this, if your blood pressure's way high, then that aneurysm is going to see very high blood pressure. But to answer your question, there's no medicine or herb or diet that you can engage in or take that can fix an aneurysm.
Right, and does it be the same for a blocked valve?
And that is exactly the same for a blocked valve.
Okay. And we have one last question. So our last question is, tell us a little bit about your program and what sets it apart from other heart doctors.
Well, I like to think in the region and throughout the United States that heart programs do an excellent job taking care of patients, which they do. In our particular program, we've certainly put an emphasis on high quality and high safety. And that seems to have benefited the patients, because when they get surgery, we are able to get them extubated very quickly and well very quickly, moving and walking down the hall the same day of surgery. So I think if we've had some success that's maybe a little bit unique, we get patients through their surgery and well fairly quickly by focusing completely on safety and quality through the entire spectrum of care. When I talk about spectrum of care, I actually am referring to the first minute that we meet the patient and get to understand them and their medical background, and taking that forward all the way through the episode of care in surgery and then after surgery. A lot of emphasis on safety and quality.
And so with that being said, with the safety and quality that you focus on, you all have earned some accolades. I believe it's the top 10% awarded by the...
Yeah, it is a, well, let's put it this way. In the United States, cardiac surgery programs participate in a national database. And so each patient has 600 or 700 data elements entered into this national database. And in a national database of that size, there's very good information that would predict, based on the 1 million or 2 million patients that preceded this patient in particular, would predict this patient's risk factors for surgery. Okay, so all programs participate in this. They get information out of the database about what their predicted outcomes and complications are and how well they're doing. It's a healthy way to engage in continuous quality improvement. In this particular program, if you do well over a year period with outcomes and quality, then and you are statistically different than the rest of the programs in the country in either a good or a bad way, you get a higher or lower ranking. That gives you a chance to kind of re-up what you've been doing if it's good, and change things if it's not. But as it turns out, it's a 3-star system. There's 1 stars, 2 stars, 3 stars. Most of the programs that are doing excellent work get 2 stars because they're right where they're supposed to be. If you're really good over a period of year and patients do really well, you can get 3 stars. And we've been lucky enough to have a couple of runs of getting a 3-star rating. So that's been good and gratifying.
Perfect. And so
we have one last question.
Perfect, yes.
Yep. So Terry just asked, so let's tell us a little bit about your team. Who do patients meet with other than you?
That's good, Terry. Thank you for that. So the team involves people that work by the bedside and take care of the patients. In cardiac surgery, we call them advanced practice providers, and those can be physician's assistants or nurse practitioners. But those people that have extensive cardiac surgery experience are incredibly important to the process, and an incredible anchor for the patient right from the very beginning when we first meet them, through surgery and after.
Are there any more questions?
Nope, we're good.
Okay, so if a patient wanted to make an appointment, or do they go through their cardiologist and then are they referred to you?
That's generally the way it works.
Okay.
So a patient that's kind of new to thinking, I've got a strong family history, or I've been having some problems or some symptoms, I need to see somebody, they can start with their primary care physician. But if they're pretty sure they're having heart symptoms, they can find a cardiologist and start there.
Okay.
That's usually where it starts. And then if the cardiologist, who is usually the one to handle the heart conditions or do diagnostic tests, finds out that the patient, by evidence, right? We all work now in an evidence-based age, but there are a lot of procedures in cardiovascular health that, by the highest level of evidence possible, there are procedures that need to be done to save lives.
Yes.
And the cardiologists are attuned to when those, we call them again, trigger points occur.
So a cardiologist can essentially call you to tell you, hey, I've got this patient who will need surgery.
And by the current recommendations, the way it works best, as the way it usually works best, it's a team approach. right? So the way the American Heart Association guidelines actually state it, it's a heart team approach. So, for example, the cardiologist may be seeing a patient and they've had a heart catheterization, and they call for the heart team discussion, where they want us the surgeon to look at the films with them and decide is, first of all, is a procedure warranted, and what's the best procedure to do, and that's the heart team approach.
So you're kind of in the network already with the cardiologist.
Indeed. Constantly.
Perfect. And so I'd like to thank you for your time today, for joining us, and thank you to everybody who's been watching. If you want more information about our cardiac surgery program, you can visit us on the web at www.umcapitalregion.org/heart. Again, that's umcapitalregion.org/heart. Thank you for joining us today.
Okay.